I'll show you the flexible laryngoscopic video of a patient having a normal larynx. You can see the normal appearance and mobility of the vocal cords, the various subdivisions of larynx. The various subdivisions, they are the piriform fossa on both sides, the postcricoid area, the arytenoids and the aryepiglottic fold on both sides, the true vocal cords, then the false cord, and on phonation or deep breathing, there is abduction and adduction of the vocal cords. You can also see the epiglottis, base of tongue, medial and lateral glossoepiglottic fold with vallecula in between them, and also the opening of piriform fossa. See, it is seen beautifully on both sides. So only after, if you know the correct anatomy, normal anatomy of larynx, then only it will be able to go for a correct diagnosis of various disorders, various abnormalities. This is a mass in the one mass in the supraglottis and another at the level of glottis. The patient presented with hoarseness and breathing difficulty. You can see the two globular masses, one above and the other at the level of glottis. This is another patient, case of malignancy, hypopharynx with extension to larynx, excessive pooling in piriform fossa and also at the level of larynx with a critical glottic space. The patient presented with a stridor and also dysphagia. See the pooling, and this is a case of phonatory gap. It's not closing properly, vocal cords with phonatory gap. And also this is another case of a mass in the larynx. See, at the level of at the vocal cords. So there are various disorders affecting the larynx and also the hypopharynx. So today I will teach you about the various subdivisions of hypopharynx, the anatomy of laryngopharynx, and also the methods of examination of larynx. Okay. After examination of oral cavity and oropharynx, we have to continue with examination of larynx and laryngopharynx. So examination of oral cavity and oropharynx and the common symptoms of the patient were discussed in previous class, and also anatomy of larynx was explained in detail in two parts previously. Now you must know that these three areas, one, here comes the nasopharynx, then from the level of palate up to the, this is which bone? Hyoid bone. So a line passing through the lower border of hyoid bone. This part is the oropharynx, and from the lower border of this hyoid bone up to the lower border of cricoid cartilage. Okay. At the level of cricoid cartilage, lower border of cricoid cartilage, the esophagus starts its course, and it is demarcated by the upper esophageal sphincter or the cricopharyngeal muscle. Okay, musculature. So that part is the laryngopharynx, or otherwise called the hypopharynx, this area. Okay, and actually this larynx or the laryngeal inlet, it forms the anterior wall of hypopharynx. So you know what is the oral cavity, the anatomy of oral cavity, the anatomy of oropharynx, and also you know the anatomy of larynx. Now what is hypopharynx? What is hypopharynx or the laryngopharynx? What is the anatomy? So this picture shows you at the level of tongue. If you are looking from above, if you are cutting at the level of tongue and looking from above, this will be the picture. I already told in the class of oral cavity that tongue is divided into an anterior 2/3 and a posterior 1/3 by what structure? That is the circumvallate papilla. So this is circumvallate papilla. Then the sulcus terminalis. Isn't it? Sulcus terminalis, and what is this? What foramen? Foramen cecum. Okay, so this part is the foramen cecum. So the part anterior to this sulcus terminalis, foramen cecum and the circumvallate papilla, that is the anterior 2/3 of tongue, which is included in the oral cavity, and the part posterior to that is the posterior 1/3 of tongue, and that is included in the oropharynx. Okay, don't forget that. And what is this thing? This is tonsil. So tonsils are situated between the palatoglossal or the anterior tonsillar arch and the posterior tonsillar arch or the palatopharyngeus muscle. Okay, so this is anterior pillar, palatoglossus, and this is palatopharyngeus. Okay, that is posterior pillar. Don't forget that. And between the anterior pillar and the posterior pillar lies the tonsil. Okay, and this is epiglottis, right? This one, this area. So that is epiglottis. And from posterior 1/3 of tongue, a median, you see, there is one median and two lateral. What? Glossoepiglottic fold. So this is median epiglottic fold, glossoepiglottic fold, and this is lateral glossoepiglottic. From gloss means tongue to the epiglottis. So lateral glossoepiglottic fold. And between these two lies your vallecula. Okay, vallecula. Okay, so this picture, roughly this part, you can see by an indirect laryngoscopic mirror. So from the epiglottis, glossoepiglottic fold, medial and lateral, between that comes the vallecula, and then this is the false cord, and this is the true vocal cord and arytenoid, and on the sides of that there is two potential spaces called pyriform sinus. Okay, and posterior to this posterior surface of arytenoid comes the postcricoid area. In this picture, this part, that is from the lower border of the arytenoid up to the lower border of the cricoid, that is the area posterior to the posterior plate of cricoid, comes the postcricoid area, and also from this part to this part, that is the posterior pharyngeal wall. Right? So the hypopharynx is actually an area which lies posterior, okay, behind or posterior to the larynx, and also on the sides of larynx. Posterior or behind and also on the sides of larynx. That is hypopharynx or laryngopharynx, and it has three components or three subdivisions, which are the pyriform sinus, postcricoid area, and also the posterior pharyngeal wall. What are the boundaries of this hypopharynx? Anteriorly, this part, and this is hypopharynx. I color it blue. This is actually, this part is a hypopharynx. So it is continuous above with the oropharynx, and below it is continuous with the esophagus and the cricopharyngeal sphincter, right? So anteriorly it is bounded above by the laryngeal inlet and below by the posterior surface of arytenoid and also posterior surface of the cricoid lamina, which is otherwise, that part is otherwise called the postcricoid area. So above it is bounded by larynx or the laryngeal inlet. This is the laryngeal inlet, and above and superiorly by the part of epiglottis and lateral sides by ariepiglottic fold, arytenoid on both sides. Okay, so upper part of hypopharynx, anterior boundary of the hypopharynx. On the upper part is a laryngeal inlet, and on the lower part it is a posterior surface of arytenoid and the posterior lamina of cricoid cartilage. Okay, so that part forms the postcricoid area. Clear? And another important subdivision of the hypopharynx is the pyriform sinus. So what are the boundaries of pyriform sinus? Pyriform sinus is very important. And what are the boundaries? So laterally, what comes here? Laterally, this part, what is here? It's a thyroid cartilage, right? So pyriform fossa is bounded laterally by the thyroid cartilage. Here comes the thyroid cartilage. Okay, and medially, from this figure it's very easy to remember. Laterally thyroid cartilage. What is the medial boundary of pyriform fossa? Medial boundary is the ariepiglottic fold, arytenoid and also cricoid. Okay, the posterior plate of cricoid, a small part comes here, and it extends from the lateral glossoepiglottic fold to the upper border of esophagus. Extending from the lateral glossoepiglottic fold or the base of vallecula to the upper border of or the up to the esophagus. So that is pyriform fossa. Laterally by thyroid, medially by ariepiglottic fold, arytenoid and the cricoid, extending from the lateral glossoepiglottic fold up to esophagus. Okay, and actually this pyriform fossa is or the pyriform sinus is a potential space. Like what is name one another potential space in the nasopharynx? Fossa of Rosenmuller. Like that, it is also a potential space and it is shaped like an inverted pyramid. Okay. It is shaped like this with a wider base and a narrow apex. And there are some peculiarities of this pyriform sinus which are very important. One, I already told you, especially the apex of the pyriform fossa, because it is an inverted pyramid. This apex of the pyriform fossa is a hidden area. So early malignancies in this area there is chance of missing the early malignancy in this hidden apex of the pyriform sinus. That is number one. Two, this area, so one, hidden area. Two, rich in lymphatics. So, rich in lymphatics. Okay. So, what is the importance? It is rich in lymphatics. So, in early stages of malignancy, it will present as an and this lymphatics will drain into upper deep cervical lymph node. So, the late stages, the malignancy will present as a neck node. Okay. So, that is second. Third, what is the third importance? It is a common site of lodgement of foreign body. Okay. Fourth, one superior laryngeal nerve seen on the under the mucosa of the lateral wall of pyriform sinus. Superior laryngeal nerve. This part. Superior laryngeal nerve is present behind the mucosa on the lateral wall of pyriform sinus. So, we can anesthetize superior laryngeal nerve. I explained about Gallen's anastomosis along with anatomy of larynx. Gallen's anastomosis is, controls the entire nerve supply or the sensory supply of larynx. So, by anesthetizing this area, we can anesthetize the sensory innervation of larynx. Okay, so that is superior laryngeal nerve which is seen behind the mucosa of the lateral wall of pyriform sinus. And fifth one, pooling. Very initial, early stages only is itself you can see pooling in the pyriform fossa in cases of obstruction to the food passage. If there is dysphagia, there will be a pooling in pyriform fossa, and that is called the Jackson sign. Jackson. Okay, so 5 things I told about the pyriform fossa. I told about the boundaries of pyriform fossa. It extends from the lateral glossopepiglottid fold or from the vallecula up to the esophagus, and it is a potential space. It is a hidden area of malignancy, and it is rich in lymphatics. So the late stages malignancy will pyriform fossa or hypopharyngeal malignancies will present as neck nodes, and it is a common site of lodgement of foreign body. Then superior laryngeal nerve passes behind the mucosa on the lateral wall of pyriform fossa, so we can anesthetize that area. And also Jackson sign, which is pooling, is an early sign in case of obstruction to foot passage. Okay, so that is about pyriform sinus. And what about this postcricoid area? I already told it extends from the posterior surface of the lower border of arytenoid to the lower border of cricoid cartilage. And again, actually in neck examination we do the laryngeal crepitus. Okay, so laryngeal crepitus. What is this laryngeal crepitus? That is, if you move, catch hold of the laryngeal framework and move it sideways with a posterior pressure. So actually the cricoid lamina should move over the, what comes here? Cervical vertebra. So this cricoid lamina should move over the cervical vertebra. So we will get a grating sensation. Okay, there is no sound, it's only a sensation, a feeling, a grating sensation. See, you will get it. You can see, do that on yourself. Okay, so that is called the laryngeal crepitus or Okay, so this sign or laryngeal crepitus, if present, or that grating sensation is called this Muir sign, and if this sign is absent, we call it as Boca sign. This is usually asked as MCQs. Okay, so the presence of laryngeal crepitus is Muir sign, this thing, and if it is absent, it is Boca sign. If there is no laryngeal crepitus, it is called Boca sign. Don't get confused between these two. At least you remember this. At least you remember Boca sign. If you can't remember the other sign, Muir sign, just forget it and remember the Boca sign, which is absent laryngeal crepitus. This posterior cricoid lamina is not moving over the cervical vertebra. So there should be something in between, isn't it? Something should be in between to obstruct this movement here. Okay. So what are the conditions which causes a positive Boca sign or an absent laryngeal crepitus? One thing, it is post-cricoid malignancy. Okay, this malignancy is filling here, so it cannot move over the cervical vertebra. So one is post-cricoid malignancy. Second, after radiation or after radiotherapy to the post-cricoid treated. Again, after radiation, there is chance of inflammation, fibrosis. So again, this cricoid lamina will not move over that. So that is second. Third, presence of foreign body with an acute retropharyngeal abscess. Because there is pus is collected here, so again this cricoid lamina cannot move over that freely. So acute retropharyngeal abscess, long-standing acute retropharyngeal abscess, and again laryngeal injuries, laryngeal trauma, this crepitus will be absent, and also perichondritis of the cricoid cartilage. In 5 conditions, I said 5. What are they? 1. Post-cricoid carcinoma. 2nd, post-irradiated larynx. 3rd, long-standing acute retropharyngeal. Acute, I said acute because of penetrating trauma. Acute retropharyngeal abscess. 4th, laryngeal trauma. And 5th one, perichondritis of the cricoid cartilage. So these are the conditions in which there is no laryngeal crepitus will be absent. So now I explained anatomy of hypopharynx, which is seen along with the larynx, on behind and also on the sides of larynx. Okay. Oh, hope you know the subdivisions and also the extent of each subdivision. And what will be the complaint of the patient if this larynx and hypopharynx are affected? What will be the complaints? One, there will be frequent clearing of the throat. That is number one. Second, any affections on these vocal cords will cause disorders in or the change in voice. So, frequent clearing of the throat. Second, voice changes. And then, if it is going into the from the larynx, if it is irritating the trachea, what will happen? There will be cough also. So, frequent clearing of the throat, then voice changes and also the cough if it is coming anteriorly. And what will happen if it go to the hypopharynx? Any affections of the hypopharynx will present as dysphagia, difficulty in swallowing, pain in the throat, painful swallowing. All this will happen. And also there will be features of acidity, especially in LPRD. It's a reflux from esophagus to this area again will cause sensation of lump in the throat, feeling of foreign body sensation in the throat. All these will be the usual complaints. Examination of the oral cavity, oropharynx. You have to continue with the examination of larynx and hypopharynx. What are the method of examining the larynx? One is by an indirect laryngoscopy and second is by direct laryngoscopy. Okay, so indirect laryngoscopy examination and direct laryngoscopy examination. And this direct laryngoscopy examination can be again, it can be rigid and also it can be flexible. Okay, using a rigid laryngoscope or a flexible laryngoscope. Of this, the indirect laryngoscopy examination is very commonly or routinely done in our OPDs using an indirect laryngoscopic mirror. You have to differentiate it from a post-nasal mirror. The post-nasal mirror has got a curve here, but indirect laryngoscopic mirror is straight. The patient is seated in front of you. You should have a good illumination and focus the light on the mirror. Explain the procedure to the patient. Ask the patient to open the mouth, and if the patient is very apprehensive or if there is excessive gagging, you can spray 10% xylocaine into the patient's throat. Okay. Explain the procedure to the patient and take the indirect laryngoscopic mirror of correct size. There are various sizes available from 1 to 5. So take the, for adult we usually take, this is number 4. For this is adequate for adult. 4 or 5 is adequate for adult. And warm it, otherwise there will be fogging inside the mirror. So warm and test the temperature. Otherwise, if you are not tested the temperature, you may burn the patient mucosa, oral cavity mucosa. So patient is seated in front of you. Explain the procedure to the patient. Get an correct illumination and warm the mirror and temperature test it. And ask the patient to open the mouth and using a gauze, ask the patient to open and protrude the tongue, and you hold the tongue of the patient with your index and your middle fingers like this, and this index finger should be on the upper lip or on the upper teeth of the patient so that the patient will not close his mouth. Okay, so ask the patient to open the mouth, then hold the tongue with this thumb and the middle finger, and with the index finger keep it over the upper lip or on the upper teeth so that the patient will not close. Then introduce the mirror with the open mouth, introduce it, and when you reach the level of uvula, just push it upwards. Don't touch on the posterior pharyngeal wall. What will happen if you touch on the posterior pharyngeal wall? There will be excessive gag and excessive difficulty for the patient. Even if the patient is anesthetized, there will be irritation to the patient. So don't scratch on the posterior pharyngeal wall. Just keep it and push the uvula and the soft palate upwards. Now the mirror is here. Okay, so what all structures can you see? See, the mirror is here. So the first thing you see will be the base of tongue, and I am drawing it here. This indirect laryngoscopy finding is usually asked in drawing label section, and also in exams you have to draw it. So you should know how to draw that. Okay, so first draw the round of mirror. You are seeing through the mirror, right? So draw that. And what is the first thing you are seeing? At this level, you are seeing the base of tongue, and also you are seeing the epiglottis. Which surface of epiglottis? You are seeing this surface. That is the lingual surface of epiglottis, not the under surface. You are seeing the lingual surface. This is exactly the picture you are getting by an indirect laryngoscopy. Okay, so the base of tongue, this part, the first thing you see is the base of tongue. Then you will get the epiglottis, part of epiglottis. Okay, which surface of epiglottis? You see the lingual surface of epiglottis, and also the vallecula. Sometime you can see the median glossoepiglottic fold, and also the lateral glossoepiglottic fold, and also the vallecula. And after that, what you are going to see, when you tilt it, you see the vocal cords. Okay, you see the false chord, and also you will see the true chords, right? This 2, 1, and after that, when you tilt it, you will see the arytenoids and also the aryepiglottic folds, right? You will see the arytenoid and also aryepiglottic fold like this, and then also you will see the pyriform fossa. You will not see the postcricoid area. Okay, this postcricoid area you cannot see by this. So you will see the base of tongue, median and lateral glossoepiglottic folds, vallecula, the lingual surface of epiglottis. You will see the false chord, the true chord, arytenoid, aryepiglottic fold, and also the vallecula on both sides. Then, with keeping this mirror inside, ask the patient to breathe normally, so that you can see the abduction of the vocal cord. On breathing, you can see the movement. And after that, ask the patient to say ah. So what will happen? If the patient say ah, there will be adduction. Okay, there will be adduction of the vocal cord. This vocal cord will adduct. And now ask the patient to say e. So what will happen? There will be adduction as well as tension. Okay. It will be adduction only, A for A, adduction only, and for E there will be adduction as well as tension of the vocal cords, and also this pyriform fossa will open. If there is any pooling, you can notice that also. So that is it. Now, if there is normal mobility, you have to represent it is like this. Normal mobility of the vocal cords are represented like this. If there is restricted mobility, you have to represent like this. Okay, so that is about indirect laryngoscopy. And there are some blind areas in indirect laryngoscopy. The areas which cannot see in an indirect laryngoscopy. What are they? Number 1 is this area. What is this area? The blind areas in an indirect laryngoscopy. Okay, what are the blind areas? Number 1 is laryngeal surface of epiglottis, the under surface. Okay, the laryngeal surface. You can see the lingual surface. Okay, the laryngeal surface you cannot see. Surface of epiglottis, right? The second, in between this true chord and the false chord, there is a fold of mucosa, and that is called the ventricle. Between this true chord and the false chord, actually there is ventricle. That is not seen by an indirect laryngoscopic mirror. So ventricle is not seen. Then can you see the anterior commissure here? No, you cannot see. So that is another blind area. Then the fourth one, you cannot see the undersurface of true vocal cord, the undersurface. Okay, so that is undersurface of vocal cords. Then the 5, postcricoid area. Okay. And number 6, apex of pyriform fossa. I said it is like this. So this apex you cannot see. So the apex of pyriform fossa. Right? These are the blind areas you cannot see. That is the laryngeal surface of epiglottis, the anterior commissure, the undersurface of vocal cords, the area between the true cord and the false cord, that is the ventricle, postcricoid area, and also the apex of pyriform fossa. Okay, so this is how you have to examine the larynx, and you have to represent it with this. Regarding this direct laryngoscopy examination, I will explain in another class.